And now I am pleased to introduce our speaker tonight, Dr. J. William Robbins, who will be speaking on 456 Global Diagnosis. Dr. Robbins maintains a full-time private practice and is an adjunct clinical professor in the Department of Comprehensive Dentistry at the University of Texas Health Science Center at San Antonio Dental School. He graduated from the University of Tennessee Dental School in 1973. He completed a rotating internship at the Veterans Administration Hospital in Leavenworth, Kansas, and a 2-year general practice residency at the VA Hospital in San Diego. Dr. Robbins has published over 80 articles, abstracts, and chapters on a wide range of dental subjects, and has lectured in the United States, Canada, Mexico, South America, Europe, Middle East, and Africa. He is a diplomat of the American Board of General Dentistry, a past president of the American Board of General Dentistry, the Academy of Operative Dentistry, the Southwest Academy of Restorative Dentistry, and the American Academy of Restorative Dentistry. Welcome, Dr. Robbins. Thank you for joining us tonight.
Thank you, Dr. Pendekar, for the nice introduction. It is indeed a pleasure to be with you tonight. I'm honored to have been invited to share some ideas with you tonight, and we'll get our program going. I really appreciate the large number of people that showed up for this meeting tonight. I, like you, practice dentistry, and I've been at the chair since Monday morning, and I'm a little weary of dentistry, and so I'm really impressed that this many people would come out for a lecture from a stranger on Thursday night. So thank you so much. I take that responsibility seriously, and I'm going to try to make this as interesting as it can for you guys to hold you to the end. So my subject tonight is global diagnosis, but I thought I'd also throw in a little DSD, digital smile design, because I think it's a good way to show the synergy and also the way to implement global diagnosis into a modern dental practice. So we're going to start off with the global diagnosis concept, and then we'll do a little DSD at the end. So what is global diagnosis? I know it doesn't mean a lot to most of you because it's a term that I made up. And my partner, Jeff Rouse, and I started working on this concept 25 years ago. And the credit for this goes to Coys and Spear. And I don't think it's any surprise to most listening tonight that John Coys and Frank Spear are responsible for a lot of wonderful things that have happened in dentistry in the last 4 decades. And early on in those days, in the late 80s, early 90s, the way a comprehensive case was treatment plan was using articulated study cast, and it was treatment plan from centric relation forward. And Coys and Spear came along and said, you know, that doesn't make any sense. Now, they still both teach that we have to pay attention to condylar position. But what they said was, in those days, we should be treatment planning the patient from incisal edges of the maxillary anterior teeth back instead of the other way. In other words, the case should not start with condylar position. It should start with incisal edge position. This made total sense to me. And I was an early adopter of facially generated diagnosis. But as Jeff and I worked with it, we started finding things that we felt we could add to it. And so global diagnosis is additive to facially generated diagnosis. All of the credit goes to Coys and Spear for coming up with this amazing idea 4 decades ago. And when they first started, their emphasis was on incisal edge position. And you're going to see tonight that our emphasis with global diagnosis is actually on the gingival levels. And that's why there's a synergy between facially generated diagnosis and global diagnosis. So global diagnosis is like putting a piece of the puzzle together. And so the first thing we're going to do tonight is we're going to take some of those pieces of the puzzle and define them. I'm going to talk a little bit about the science of beauty. Most of the things I'm going to say are things you already know. They're not new to you. However, there may be some because many of these things are not really taught in dental school. So I'm going to go over just a handful. And obviously, this is a shortened version tonight of a longer program. So the first thing I start looking at with a new patient is the same thing that you look at, and that's the entire face. And everybody is familiar with the facial proportions rule of thirds. The upper, middle, and lower thirds of the face should be 1 to 1 to 1 in the proportional patient. In the dental patient, we don't really care about the upper third. We're only interested in the middle and the lower third. So the first thing you have to remember is where these measurements are made from, or this doesn't help you. So the midface is measured from the most prominent point between the eyebrows, or glabella, to under the nose, And the lower third is measured from under the nose to under the chin. And you'll notice that the lips are lightly apart in a reposed position. Here's the same view from the sagittal. Mid-brow point to under the nose to under the chin, 1-to-1. The second proportion that's helpful to me is the lower third. And if I draw a line through commissure, above that line is maxilla, below that line is mandible, and that proportion is 1/3 to 2/3. So I can now very quickly look at a patient's facial presentation and determine by looking if there's going to be a vertical skeletal component to my diagnosis. I don't have to have a cephalometric x-ray to start with, and in fact, I don't, as a general dentist, start my comprehensive exam with a cephalometric radiograph. The next thing I look at is the sagittal or profile view. And this is the most classic way that we have been taught to look at a patient in profile. And that's the Ricketts E line. Dr. Ricketts was an orthodontist many years ago, and E stands for aesthetic. And what Dr. Ricketts told us is that if you draw a line on the nose and the chin, as we see on this diagram, those are the number of millimeters behind that line that the upper and lower lip should fall. However, there are a couple of problems with the Ricketts E line. The first problem is that it was described in 1960. And remember what we had been doing back in those days, back in the late 60s, 70s, 80s, we were extracting premolars and doing retractive orthodontics, which resulted in a flatter facial profile. That's no longer our standard. Today, we much prefer a more procumbent facial presentation because, first of all, it looks good, and secondly, it's more healthy from an airway point of view. So that's the first problem. I think it's an antiquated view of the profile. The second problem with the Ricketts E line is that it works sometimes on Caucasians. It almost never works on people of color. So this is Belinda. Belinda is my office manager. And I think we would all agree that Belinda is a beautiful woman in the frontal view. I think we would also agree that she's a beautiful woman in the sagittal or profile view. However, she doesn't fit within the norm that Dr. Ricketts gave us 60 years ago. We can see that her lips are actually touching and to some degree in front of the line, which means her lower third is more procumbent than the classic Ricketts E line. And yet, I think she's a beautiful woman. So I no longer use the Ricketts E line in my diagnosis of patients. I use two other lines today. The first was also an old one from Dr. Andrews, another orthodontist back in that time frame. And what Dr. Andrews said, if you have a patient looking straight forward, natural head position, NHP, natural head position, and you drop a line vertically from glabella, the facial surfaces of the macular central incisor should be on that line. So this is a really very helpful starting point for me as a restorative dentist when I'm looking at the position of the maxillary anterior teeth in relation to the face. It's also a great starting point if we're doing removable and we're trying to determine where to put a tooth and a rim in an AP position. So we look at Belinda and we can see when we drop a vertical from her forehead, Andrew's line, that her macular central incisors are right on that line. The second line that I find helpful is Arnett's true vertical line. Dr. Arnett was an oral surgeon, and your part of the world, one of the most famous ever, doing orthodontic surgery. And he did a lot of research during his years. And in this line, you drop a vertical from the nasolabial angle, and that's the number of millimeters in front of or behind that line that the upper lip, the lower lip, and the chin should fall. So these are the two primary ways today that I evaluate a patient based on photography in the sagittal view. The next thing I look at is the transverse symmetry of the face. And as we look at this young woman, we can see that everything about her face is asymmetrical. She's got a long side, a short side. She's got a canted interpupillary line and a canted maxillary occlusal plane. So this is the last thing that I pay attention to in my macro view of the patient. Ultimately, I'm going to go back to the operatory and I'm going to measure from mid-brow point to under the nose, and I'm going to get a number. And I'm going to measure from under the nose to under the chin, and I'm going to get another number. And I'm going to go to this form. And I'd be happy to share this form with you if you drop me an email, and I'd be happy to send it to you electronically. It's a powerful form that leads you through this global diagnosis process. And I put mid face is 70, the lower face is 71, and I now have the first piece of the diagnostic puzzle solved. It's interesting to me that the people that talk about facial diagnosis all talk about the rule of thirds and facial proportions, but almost nobody talks about the upper lip. And in our systematic approach, the upper lip is one of the 5 most important things that we evaluate. So we're going to look at 3 important things about the upper lip. The first is the average lip length in the young patient. And when I say young, I'm talking about 25 to 30 years of age. So if we measure from under the nose to the wet, dry border of the upper lip, the average young female lip is 20 to 22, and the young male 2 millimeters longer. And I know what you're thinking. You're thinking, with all of my patients that have big heads and little heads, and wide heads and narrow heads, this 20 to 24 millimeter range is pretty narrow. And I'll tell you, I've been seriously measuring lips for the last 25 years, and I am always impressed with how often my patients fall within that 20 to 24 norm. And if they don't, how often it impacts my treatment plan. So these are real numbers that really work in your clinical practice. The second thing we know about the upper lip is that it's going to lengthen as the patient ages. It's a normal part of the aging process. And a rough rule of thumb, starting at age 40, the upper lip will lengthen 1 millimeter per decade. So there we are on the left with a 25-year-old female, and she's got a 20 millimeter long lip, which is normal for her. We fast forward 50 years to age 75, and now the whole frame of her smile has dropped. She's lost volume in her lips and her perioral tissues. She now has incisal display of her lower incisors rather than her upper incisors. And as every dentist watching tonight knows, this is a very difficult starting point for the restorative dentist to have incisal display of the lower incisors. And that's the reason that lip dynamics are so important. The third thing we have to know about the lip is the mobility, and that's measured from the repose to the full smile position. And the average lip mobility is 6 to 8 millimeters. On the left is the repose position. On the right is the full smile position. 6 to 8 millimeters is normal. It's not unusual for you to have a patient that has a lip mobility of 10, 11, 12 millimeters. And that becomes a definitive diagnosis for that patient, and yet it is almost universally left out. So now we know 3 very important things about the upper lip: the average lip length in the young adult, the knowledge that the lip will lengthen as the patient ages, and the normal lip mobility from repose to full smile. The next guideline: natural smiles display asymmetry within symmetry. Outline symmetry is essential at the midline. So as everybody knows, in a beautiful smile, it is very important the maxillary central incisors be mirror images of each other. However, it's not necessary that the laterals and the canines be mirror images of each other. And in fact, everybody listening tonight as dentists all enjoy the look of a natural God-given smile rather than that prosthetic smile straight across. However, it's important to know what matters and what doesn't matter. Verticality of the midline is also equally important as symmetry. So the 2 key issues at the midline are that the midline be perpendicular to the horizon and that the maxillary central incisors be symmetrical. It is not essential that the maxillary midline be in the middle of the face or coincident with the lower midline. It can be up to a couple of millimeters off of the middle of the face, and it really has no impact on the aesthetics. The keys are verticality of the midline and symmetry of the central incisors. The next guideline: the incisal plane should be parallel to horizon. And we all know that. That's something we all learned in dental school, and it's true. I think it is a very good starting point to determine a patient's incisal and occlusal plane. However, most of our patients are not parallel with horizon. Again, I've been paying attention to maxillary occlusal planes now for many, many years, and it's a very unusual month when I have a single new patient come to my practice whose maxillary occlusal plane is parallel to horizon. Almost everybody has a cant, some a little bit, some a lot. The next guideline: in an anterior posterior plane, the buccal cusp tips of the posterior maxillary teeth should be a continuation of the anterior smile line. So that's a lot of words to just say something that's common sense to us. And that is, when we go from the front teeth to the back teeth, it's really important that we have a smooth transition with no step up or step down. This is the step up that I'm talking about from canine to first premolar. And we all know that this is a disaster functionally, and it's even worse aesthetically. So this is something we never want to create with restorative dentistry, and that's a step up from front to back of the mouth. However, this is just the opposite. This is a step down gingivally from front to back. And one of the most unpleasing aesthetic presentations is increasing gingival display as we move posteriorly, as we see in this patient. So he has no gingival display in the front, and it increases up to at least 5 millimeters in the back. And this is a significant problem for this patient from an aesthetic point of view. Either the anterior maxilla is too long, or it's too short, or the posterior maxilla is too long. So we've got three ways that we can fix this. The first way is with crown lengthening. And I think if we look closely, we would all agree that crown lengthening is not a good choice here because we'd be up on roots and endoforcations. So that leaves us either with orthodontic intrusion or orthodontic surgery. I think it's incumbent upon us, if we're doing a comprehensive exam on a patient and his facial display, his aesthetic display is a concern to him, we should be talking not just about the wear on his front teeth, but also the increasing gingival display as we move posteriorly. All right, let's talk about the two borders of the smile that impact us most often, and that's the upper and lower lips. And let's start with the lower lip. This is my idea of a beautiful smile. The incisal edges of the maxillary anterior teeth are cradled by the lower lip in full smile. There it is diagrammatically, and we all love this look, and we all like to treat to this position. If we've got teeth that are a little short, we like to treat to incisal edges lightly touching the lower lip. However, neither you nor I live in a perfect world, and it's not uncommon for a patient to present with this space between the incisal edges and the lower lip. And I think this can be an equally beautiful smile as long as two criteria are met. The first criterion is that the space must be uniform from right to left. If it's larger on one side than the other, that's an aesthetic detractor. And if it's larger in the middle, that's the worst. That's the reverse smile line. So the first criterion for success is the space must be uniform. The second criterion for success is that the space must be less rather than more. Now, what do I mean by that? Well, if those are 10 to 11 millimeter long central incisors, then that space between the edge and the lip is probably about 3. And that amount of space works beautifully. It frames the teeth and it still looks good. However, if we triple that space up to 7, 8, 9 millimeters from incisal edge to lower lip, all of that negative space tends to diminish the visual appearance of the front teeth and makes them look small. That's something we never want to do. We don't want to make the front teeth look small. So I like edges on the lip best. I like a space as long as the space is uniform and it's less rather than more. Ideal on top, the bottom's okay as long as it's not a large space and it's symmetrical. Let's now talk about the other border of the smile, and that is the upper lip. But first of all, I want to talk about a couple of parameters. The first is the important one that Coys and Spear gave us 4 decades ago, and that is the incisal display and repose. And as we all know, the average incisal display and repose in the young female is 3 to 4 millimeters, and in the young male, a couple of millimeters less because on average his lip is a couple of millimeters longer. And obviously we're going to have decreased incisal display as the patient ages, due both to lengthening of the lip and wear of the incisal edges. The other parameter related to the upper lip is a line I'm going to call the gingival line. And it's drawn from canine to canine at the tooth gingiva interface. And as we all know, the centrals must be on that line in the beautiful smile. The lateral can be on the line. It can be up to a couple of millimeters below the line. That's a matter of personal taste between you and your patient. However, canine, central, central, canine, those 4 teeth must be on the gingival line in the aesthetic smile. So why is this my view of a beautiful smile? Well, it's the teeth that make it so beautiful, and we want to see all of the teeth with no distractors above or below. So I don't want the lower lip to be a long ways from the incisal edges because that space diminishes the teeth. I don't want the lower lip covering the incisal edges because we lose the dynamism of the teeth. Conversely, on the upper, I don't want the upper lip covering part of the necks of the teeth, and I don't want the upper lip going way up and showing 4, 5, 6 millimeters of gingiva. So in a perfect world, the lower lip is cradling the incisal edges, and the upper lip translates right up to the gingival line. So in the smile, we see teeth with no distractors above or below. The last guideline is one that everybody knows, and that's the length of the maxillary central incisor on average is 10 to 11 millimeters long. However, it's not just the length of the tooth, it's also the height to width ratio. The average height to width ratio of the central is 1.2 times taller than it is wide. Another way of saying exactly the same thing is the maxillary central incisor is about 80% as wide as it is tall, which means if you have a 10 millimeter tall central, it should be around 8 millimeters wide. The last proportion that's helpful to us is the width of the lateral to the width of the central. And it turns out that it's pretty close to the same, 75 to 80%. The average lateral is about 75% as wide as the average central. So all you have to do is remember two things. You have to remember the 10 to 11 millimeters is the average length of the central, and you have to remember the ratio 75 to 80%. Width to height on the central, width to width lateral to central. And now as a restorative dentist, I'm ready to talk to the two most important people in my life on occasion, and that is the orthodontist who's redistributing space for me, and the lab technician who's doing the diagnostic workup and the ultimate restorative dentistry, or the lab work for the restorative dentistry. So we very quickly went through highlights of the science of beauty. Now we're going to use those highlights to look at several patients. Patient number one has excess gingival display, at least she believes she does, and there is a reason for it. Patient number two has a much greater gingival display, and there's a reason for it, but it's different than patient number one. And patient number three is going to look a lot like patient number two, but the reason for hers is different than the two patients that we've already seen. So here's our dilemma. We have three patients that have excess gingival display, and yet there are three very different reasons. So this is what we're going to work with for the rest of our time together. These are the four global diagnoses that we must understand to be able to do interdisciplinary treatment planning on our patients. So let's start out with the first global diagnosis, which is related to the upper lip. The first global diagnosis related to the upper lip is the short upper lip. So this is Anne. I've spent the first 25 years of my career teaching primarily, and the last 25 years of my career, I've been in private practice. So I actually saw this patient. She was the wife of a dental student many years ago. And she came to me with a chief complaint that she didn't like her gingival display. And I still remember my discussion with her, even though it's been a long time ago. I said, Anne, I think you've got a beautiful smile. In the context of your face, the amount of gingiva that you show, I don't think is problematic at all. I think it looks good. But even better, what's going to happen over the years as your friends age and their lips start to cover their teeth, your lip is going to move into a place that makes you look young, even in your elder years. And I'll never forget what she said to me. She said, Dr. Robbins, I don't really care what you think about my gummy smile. And I certainly don't care about what I'm going to look like when I'm 75. I don't like it today, and that's the reason I came to see you. So I at least now have to diagnose it. So I measured Anne's face. It was normal. Measured her teeth. They were normal. Everything about Anne was normal until I measured her upper lip. And we can see that her relaxed upper lip is only 18 millimeters long. That's her diagnosis. Anne has an anatomically short upper lip. The second global diagnosis related to the upper lip is the hyperactive upper lip. So this is a different patient. We remember the average lip mobility from repose to full smile is 6 to 8 millimeters. This patient translates 10. So just think about how much better her smile would be if her upper lip translates the normal amount, which would be on average 7 millimeters. That would be 3 millimeters less translation from repose to full smile, and it would significantly improve her smile dynamic. So her diagnosis is a hyperactive upper lip. So what do we have in our bag of tricks to treat a short or hyperactive upper lip? There is an upper lip plication surgery that's done today in some circles, and essentially it's a reverse vestibuloplasty. And that's not a procedure that I prescribe for my patients for several reasons, and I won't go into that now. So my primary treatment option for the short or hyperactive upper lip is Botox. And that's not a new or clever idea. Everybody knows that's the case today. So this is Amber. Amber is our 25-year-old female, and she has two things going on. One thing she has going on is she's got vertical maxillary excess. If we measure the middle third of her face and the lower third is long because her maxilla is grown too long. She also has a short upper lip. So she doesn't want orthodontic surgery, so we're not going to do a maxillary impaction on her. So we're going to use some Botox at the ala on either side. And as everybody knows, it's not like xylocaine. It doesn't work in 5 minutes. The first time it's administered, it takes about a week. And a week later, after it's administered, this is her big smile. And regardless of how dirty the joke we tell her, that's where her upper lip's going to go. And it generally, for the first time when it's first administered, it doesn't last but a couple of months. But the more we administer it, generally speaking, the time frames between administrations stretches out. So generally, it's going to take about 3 administrations per year to help maintain this lip position in a place that satisfies this patient. However, we can also have a long upper lip, which is the third lip diagnosis that we have to deal with. And many of you probably know Kyle Stanley. He's a restorative dentist in Beverly Hills. And he published this article in 2017, and it was an article about the lip lift procedure, a surgical procedure for a long upper lip. Now, this procedure has been around for many, many years in plastic surgery circles and oral surgery circles, but he's the one that sort of brought it to the forefront for the restorative dentist. So let me tell you about the lip lift procedure. Some people call it the bullhorn procedure, and it's for obvious reasons. A piece of tissue is removed under the nose, the upper lip, and then the lip is elevated and sutured. And you can see it's resulting in a greater amount of vermilion display. And if her lips were apart, we would see more tooth structure also. So who is this for? Well, this is the plastic surgeon that I use in San Antonio, Jose Barrera, and he's a very talented plastic surgeon. And I think this is a beautiful job that he's done. So he's done a lip lift on this patient, and she had an aged looking face and lip, and he was able to lift her lip, increase her vermilion display. Obviously, it would also increase her incisal display and repose and full smile. And I think this is a beautiful job. So I do believe that there is an indication for the lip lift procedure in our older patients. However, I have a great deal of concern about the popularity of this procedure. I was in an airport about 3 years ago, and it was an airport that had a lot of retail stores, and there was a Mac store. And this advertisement was from floor to ceiling on the window looking out over the concourse. And as I walked up and looked at it, this is some artist's idea of what a beautiful young woman should look like. And when we take a closer look, we see that she's got a short philtrum, an everted upper lip, and almost 100% incisal display and repose. My concern is this. My concern is that a young woman that's 21 years old, like the one on the left screen, is in the same airport that I'm in. And she looks at this representation of what a beautiful young woman should look like in repose, and she thinks to herself, wow, I can't see any of my teeth, or not very much of my teeth in repose. I've got a long lip compared to that. So now it's in her mind that her lip is wrong and the lip in this advertisement's correct. She then walks down the concourse and she goes to the store that sells books and magazines, and she sees Elle magazine with FKA Twigs, a rock star from the UK, with the same presentation. She's got a short philtrum, an everted upper lip, and she thinks to herself, you know, I've seen this twice in one day. I think that's what I want to have done. So she goes to a plastic surgeon, and in one quick procedure, she is now ruined. You can see the scar under her nose, because before this procedure, she had lip competence and she was a nasal breather. But now that her lip has been shortened, she has now become an obligate mouth breather. And as we know, A lot of good things happen to the air as it goes through the nose, and a lot of bad things happen when it goes through the mouth. So I personally have a great deal of concern for the popularity of this procedure in younger patients. I do think it has a place in older patients. So now I've gone through the first global diagnosis, which is related to the upper lip. The second global diagnosis is related to the short clinical crown. And it turns out that there are only 3 reasons that a patient can bring a short clinical crown to your office. The first is a normal variation. I'm going to call that microdontia, or like a peg lateral. The second is wear. And the third is altered passive eruption. Altered passive eruption is the one I'm going to emphasize tonight because the other 2 we're all familiar with. But before I talk, let's take a look at a patient. We've got a central incisor that's only 7 millimeters long, and it's supposed to be 10 millimeters long. And we cannot feel the CEJ and the sulcus. That's all that's required to make a diagnosis of altered passive eruption. We do not need a cone beam CT to make this diagnosis. All we need to do is to feel for the CEJ and the sulcus. In the normal patient, this is no anesthesia. We just gently put the explorer into the sulcus and we move up until we feel the CEJ. We go a little farther, we feel the flatness of the root, and we go a little farther and the tissue blanches. That's the patient with a normal attachment apparatus. The patient with altered passive eruption, we go up, up, up underneath the gingival crest until the tissue blanches, and yet we cannot feel anything but enamel. That's all that's required to make this diagnosis. So here's the normal attachment. There's the convexity, there's the CEJ, there's the flatness of the root, and there's the base of the sulcus where the tissue blanches. That's the normal patient. This is the patient with altered passive eruption. We go up, up, up until the tissue blanches. Yes, the tissue does attach to the enamel with a hemidesmosomal attachment that stops the explorer, and we're nowhere close to the CEJ, which is much farther up underneath the attachment apparatus. So that leads us to a very specific procedure for a very specific diagnosis. Aesthetic crown lengthening is just for one thing, and that's to treat altered passive eruption. So this is patient number 2 that we looked at earlier. And as we take a look at this patient, we can see that she's got a great deal of gingival display from front to back, and she's also got what appear to be very short teeth. So we measure her maxillary central incisor. It's 5.5 millimeters long, and it's about a mile wide. And when the ratio is 5.5 millimeters by a mile, you know that you can't feel the CEJ and the sulcus. So this is actually a very easy diagnosis to make on this patient. This is a procedure that I do in my practice, and I've been doing it now for about 30 years. So I am a general dentist, and I'm not proposing that it's important that general dentists be doing this procedure. It's generally going to be done by the periodontist. But my point is, it is not about who does it, it's about diagnosing it. Here's the good news about the procedure. The first good news is that the post-op course is easy on these patients. We do this on teenagers more than we do it on adults, 15, 16-year-old teenage girls and boys. And the post-op course is almost universally easy. It's only ibuprofen for a couple of days, and that's it. There's never a need for a narcotic after this procedure. The second great piece of news is we don't get exposed roots. And the third piece of good news, we don't get black triangles. So exposed roots and black triangles go with functional crown lengthening, and we'll be talking about that in a few moments. But with aesthetic crown lengthening, we never have to worry about either of those problems if we use the numbers that I'm going to propose to you. First of all, a flap is elevated. It's elevated 1 tooth distal to the distal extent of the smile. The distal extent of the smile is generally the mesial of the first molars, which means the initial incision should go to the mesial of the second molars. It is generally a big mistake to stop this procedure in the premolar regions because it results in a gingival step down as we move posteriorly. So we're going to elevate a flap from mesial of second molar to second molar. When we elevate the flap, it's only a buccal flap. Interproximal and palatal tissue are left intact. The bone is always too close to the CEJs in some areas, and it's almost always too thick. So we're going to thin the bone and move it 2 millimeters apical to the CEJ from line angle to line angle. Once that's done on each tooth, we're then going to reposition the tissue so that it's 3 millimeters coronal from the gingival crest to the alveolar crest is 3 millimeters. As Dr. Coys teaches us, that's a normal crest position. And obviously it should be level in this new position. So here's our patient pre-op, and we can see why the tissue only got up to 5.5 millimeters, because the bone is right on the CEJs and it's actually growing buccal to the CEJs. So this bone is going to be thinned out with high-speed instrumentation. It's much like festooning a denture. We're not just thinning the bone over the root, we're also thinning the bone between the roots to festoon it and make it look like a normal alveolus. So here she is after the ostectomy. The bone has been moved 2 millimeters apical to the CEJ from line angle to line angle and thinned. We can see the interproximal tissue is left intact. So it is a thinning incision of the papilla. About 1 millimeter of the thickness of the papilla goes up with the flap. The rest of the papilla remains interproximally. The tissue is then replaced and sutured. I prefer to take the sutures out at 5 to 7 days. I use 5-0 Vicryl in this procedure, and here she is at 5 weeks. And my idea of success when I do this procedure are two things. I want, well, more than that. I want the tissue to be level, first of all. Secondly, I want the tissue to heal with a knife edge. And third, I want no scars. That's my goal at 5 to 6 weeks. So here's our patient pre-op, and here she is post-op. And when I was taking that post-op photograph, she was just effusive with praise. And she said, you know, you really changed my life. I'm very grateful for what you did. And I said, you know, thank you, Louisa. That's one of the nicest things you could say. I said, why did you wait till you were 35 to have this done? She's a registered nurse. She's a really smart lady. And she teared up and she said, I've been going to dentist with an S, dentist, all of my life. And you're the first one that offered me a solution. So once again, I don't think it's important who does the surgery as long as they have the skills to do it well. What's important is that we make a diagnosis and get the patient to the correct practitioner to get this procedure done. Okay, I've talked about the two easier global diagnoses, the upper lip and the clinical crown. Let's move to the third, which is the most difficult for the restorative dentist, and that is dentoalveolar extrusion. Dentoalveolar extrusion means that the teeth have super erupted. And as they super erupt, they bring bone and soft tissue with them, resulting in a concave gingival line. So on the upper screen is the normal gingival line. On the lower screen is the gingival line consistent with dentoalveolar extrusion. Now I'm showing it to you in the anterior maxilla for two reasons. First of all, it's the easiest place to demonstrate it. And secondly, it's the place that it happens most commonly. However, it can happen anywhere in the head. It can happen in the upper jaw, the lower jaw, the front teeth, the back teeth. The key is that we diagnose dentoalveolar extrusion based on the gingival line in relation to horizon, not based on teeth, because teeth wear. There's three reasons that a patient can have dentoalveolar extrusion. The first is due to lack of opposing teeth. And that happens in the class 2 patient where the upper and lower teeth are not coupled, and so they can super erupt. The second circumstance is when teeth are extracted in one arch and the opposing teeth super erupt. So the first etiology of dentoalveolar extrusion is lack of opposing teeth. The second is wear. That's the most common one. And the third is a developmental cant. So I've been thinking more about dentoalveolar extrusion than the other global diagnoses over the last decade, because as a restorative dentist, it's the most difficult one for me to treat. And so far, I have come up with 9 treatment options for dentoalveolar extrusion. And I can talk to you all day about these 9 treatment options. However, there are 6 specialized treatment options and there are 3 generalized. And these are the 3 that we should be thinking about anytime we have an adult wear patient. These are the 3 primary treatment options for dentoalveolar extrusion and wear. The first is functional crown lengthening. The second is orthodontic intrusion. And the third is restoring at an increased vertical dimension. So let's look at the old way. The old way doesn't mean that it's a bad way. It just means it's the one that we've been doing most often. And we do it primarily in the patient that has short clinical crowns. So Here's our patient with short clinical crowns. Can we feel the CEJ and the sulcus on these people? And the answer is yes. This patient doesn't have altered passive eruption. This patient has dentoalveolar extrusion with wear. So it's good for a patient like Leroy. We've made a decision that we're going to do full coverage restorations on Leroy's teeth. Let's make a diagnosis. Leroy has dentoalveolar extrusion with wear, and he's lost almost all of the palatal structure on the maxillary anterior teeth. Therefore, if we prep him for full coverage restorations, we will not have enough clinical crown height for retention and resistance for him. So that's what we're going to do. We're going to create better retention and resistance for him for traditional crown and bridge. So this is functional crown lengthening. It's a palatal flap, a facial flap, interproximal tissue is elevated, and bone is removed 360 degrees. This is a much more aggressive crown lengthening procedure than the aesthetic crown lengthening. And there's the patient post-op. We now have plenty of clinical crown height for traditional crown and bridge. And if we're going to do traditional crown and bridge on Leroy, this was the right thing to do. However, anytime we have to do functional crown lengthening on a patient, we have at least 5 issues that we have to deal with as restorative dentists. The first, roots are almost universally exposed when we do functional crown lengthening. Now, that doesn't mean that we couldn't cement a crown on Leroy. We can certainly cement a zirconia crown. We can cement a ceramo metal crown. But the point is that we as restorative dentists always have to deal with exposed roots, and that's a difficult substrate to deal with. The second problem is one that people don't talk about, but is true most of the time. And that is when we do functional crown lengthening and we move tissue up on root, the tissue doesn't want to be there. It wasn't designed to be there. It was designed to approach the enamel, as we see in the upper screen. So in the upper screen, we see knife edge gingiva approaching enamel. On the lower screen, we see healthy tissue. The surgery is well done, but there's a rolled gingival margin. And the problem is that commonly when we challenge that rolled gingival margin with the margin of restoration, we get mild but chronic inflammation long-term because the tissue really doesn't want to be up on the root. The third problem, as we move up on the root, it gets narrower and it angles distally, resulting in triangular shaped crowns, which are not aesthetically pleasing. The fourth problem, we removed interproximal bone and soft tissue, resulting in either long interproximal contacts between the crowns or open gingival embrasures or black triangles. And finally, increased crown root ratio. Obviously, we removed a significant amount of bone on these teeth, so they have less osseous support. So once again, it's the right thing to do if we need to do it. We just have to be aware of the complications that we have to deal with as restorative dentists. Let's now talk about the way that I've got much more enthusiasm on, and that is orthodontically moving the teeth back where they were before. So this is where a wear patient was many years ago with normal horizontal and vertical overlap. This is what commonly happens. The patient loses incisal edge due to attrition, due to parafunction. And eventually, if it's severe, the attrition gets past the interproximal contact apically. And as it gets past the interproximal contact apically, the teeth become narrower mesiodistally. And all of that lip dynamic, that muscle force pushing on the upper teeth, move the maxillary teeth palatally. So this is a pretty common thing in the adult wear patient that has anterior and posterior wear. And that's moving into a more pseudo class 3 situation. So instead of doing crown lengthening and a full mouth rehabilitation, commonly, if we can move the teeth back into the positions they were in when they were correct, we can do fewer dentists, fewer crowns or restorations, and commonly they can be enamel bonded rather than full coverage. So what I'm going to be asking my orthodontist to do is to intrude those teeth, but also move them facially. So this is a pretty difficult thing to do because I want those teeth moved into a fairly precise position before the patient is debanded and I go in and do my restorative dentistry. So when we get to the end of the presentation, I'm going to talk about pre-orthodontic bonding. And today, my standard way of dealing with a patient like this is to any tooth that's going to be restored at the end of orthodontics is going to receive a composite restoration either before or during ortho. So what that means is if I'm going to be doing porcelain restorations on 6 through 11 and 22 through 27, at some point in the ortho, they're going to get composite restorations to make those 12 teeth anatomically correct. That then gives the orthodontist a perfect template in the mouth to finish the case exactly where the teeth need to be. It makes the ortho much more efficient, and the end game is so much easier for the orthodontist. So there's where the patient was pre-op. There's the patient intraoperatively. The teeth have been intruded. They've been moved back up to that gingival line where they were initially. That which was lost due to incisal edge wear on the teeth now become the incisal edge reduction. So I don't have to remove any more tooth structure on the incisal edges. And now that the teeth are in a good AP position, I can now do enamel bonded veneers on the upper and lower anteriors rather than having to do some type of full coverage restoration. So intrusion prior to restorative dentistry is a giant advantage to the restorative dentist. When we intrude anterior teeth, most of the time the soft tissue goes up with the teeth, as I've shown you in this diagram. On occasion, it doesn't. Sometimes when we intrude maxillary anterior teeth, the teeth go up nicely, but the soft tissue balls up over the brackets. If that happens, it requires a crown lengthening procedure. But the good news is that if the CEJs have been leveled orthodontically, then this is aesthetic crown lengthening, not functional crown lengthening. So we don't have all of the bad things that go with the crown lengthening because the teeth have been leveled orthodontically. Once they're in the correct position, we then can do our enamel bonded restorations without removing any more incisal edge off of the tooth. And then we can do our enamel bonded porcelain restorations, anatomically correct with a beautiful straight gingival line. And that's the big advantage of doing ortho prior to restorative dentistry, because we don't have to deal with any of these 5 problems when we do it orthodontically rather than surgically. So let's look at a patient. These photographs aren't very good because I didn't take them. I didn't get to see this patient pre-op. She went to an orthodontist in San Antonio, and the orthodontist started treatment, and she sent the patient to me when she was finished with treatment or near finished with treatment at about 18 months. So let's diagnose this patient. What's your global diagnosis on this patient? There's a hint. She's got a curved or concave gingival line. So that means she's got dentoalveolar extrusion, and she's got wear on 8 and 9. So this is dentoalveolar extrusion with wear. What does she look like? She looks like she's class 2 div 2 with lingual verted centrals and buccal verted laterals, but she's actually not. We can see she's got a class 1 molar relationship. She's mesocephalic on her ceph. So she is not skeletally class 2. So why does she look like this? And when I'm with small study groups and I show this, there's only one person in the room that gets the answer, and that's always the orthodontist. For some reason, none of the rest of us learned to count teeth when we were in dental school, except the orthodontist. So here's the rule. Anytime you look at a patient, either their cast or you look at their teeth in the mouth, if the upper and lower midlines are not coincident, the first thing you do is count teeth. So now obviously everybody can see she's missing a lower incisor that was extracted many years ago. So that's the reason she looks like she looks. This isn't a skeletal discrepancy. This is a tooth arch discrepancy. So this is the first data saw. And I think the orthodontist has done a beautiful job. The 2 central incisors have been brought out into a beautiful relationship to the lateral incisors. So they're aligned very nicely. They've been intruded beautifully. Tooth number 7 could be intruded just a little bit more, but by and large, I think this is a beautiful job. However, as a restorative dentist, this is a problem for me because before, when she started, her upper and lower anterior teeth were coupled. They were touching. Granted, they were ugly, but they were touching, and she was efficient with her chewing. Now at this point, she no longer has coupling of her upper and lower anterior teeth, because as the upper teeth were expanded out, there's now too much overjet. So what I quickly did was a diagnostic mock-up using composite at the end of ortho to determine if I could get her coupled with upper and lower restorations. And the answer is no, I couldn't. Obviously, there's too much overjet to get her coupled with anatomically correct anterior teeth. So I called the orthodontist up and said, thanks so much for sending the patient over. I'd like for you to do one last thing for me. I would like for you to flare the lower incisors so that I can get the upper and lower teeth coupled when I do the restorative dentistry. Now, the problem is that when we flare the lower incisors, we're going to create space between the teeth. So we got two ways to deal with space. One, we can consolidate the space and place an implant, or two, we can make 3 wide porcelain veneers. And I think we can all see that there's not going to be enough room for an implant down there. We're not going to end up with 5 or 6 millimeters for an implant. So I asked the orthodontist to flare the lower incisors. We could couple the upper teeth by retracting the uppers. We don't want to do that. That's where she was. We can flare the lowers. We do want to do that, but we have to decide which of these two ways we're going to do it. So my idea is that we're going to flare the lower anterior teeth until I can do a mock-up in the mouth to determine that I can do 3 veneers on the lower and 4 veneers on the upper and get her coupled in a stable relationship. So this is after the orthodontist has done some flaring. I've had to go in and do some mock bonding again to confirm that this is going to work, and then we're ready to go. So there's the restorative dentistry, and there is absolutely nothing special about the restorative dentistry. Many watching tonight can do more beautiful dentistry than this. So what is magic or beautiful about this case in my mind is certainly not the dentistry. What's beautiful is what the orthodontist did for me, because by aligning the upper anterior teeth, it allowed me to have a natural looking straight gingival line with no shadows. If we had done this case with crown lengthening of 8 and 9, which is the way I would have done it 30, 35 years ago, we would end up with a rolled fat gingival margin on 8 and 9, which would cast a shadow. 7 and 10 would have been over-prepared, probably requiring endo, and it still wouldn't have looked good at the end. It wouldn't have looked natural. So the beauty in this case isn't because of the restorative treatment. The beauty is because what the orthodontist did for me to make this a very routine restorative case. Okay, so we've talked briefly about dentoalveolar extrusion and orthodontic intrusion as my primary treatment option today for dentoalveolar extrusion. So this is my statement. The primary purpose of adult orthodontics is to decrease the restorative compromise. It doesn't say the primary purpose of adult orthodontics is to straighten crooked teeth. The primary purpose of adult orthodontics is to decrease the restorative compromise in 2 ways. First of all, the number of teeth requiring restorations. Probably half of the wear patients I treat in my practice have a lot of anterior wear and very little posterior wear, certainly not enough requiring restorative dentistry. In the old days, the only way we could treat those patients was to increase the vertical dimension and put a restoration on every tooth. Today, that's not the case. If the posterior teeth don't need restorations, we don't restore them. We move the anterior teeth into the correct positions, and then we can do fewer restorations. The second great thing is we can do almost universally enamel bonded rather than dentin bonded restorations when we move the teeth into their correct positions. So I'm a giant fan of sending the adult wear patient to the orthodontist prior to doing the restorative dentistry for the reasons I've just discussed. All right, let's go to the 4th and final global diagnosis, and that is the skeletal discrepancy. The skeletal discrepancy that impacts me most often as a restorative dentist is vertical maxillary excess. The cardinal findings in vertical maxillary excess are long face and significant gummy smile from front to back. So once again, I don't need a Ceph to diagnose this patient with VME. I can do it just by looking at her face. So we look at the left screen with the full smile, and we can see that she's gummy from front to back. That's a giveaway of VME. We then come to the right screen and we do the measurements. And we can see that the lower third of her face is significantly longer than the middle third, and the maxilla lives in the lower third of the face. That's the reason she's got a long lower third, because she's got vertical maxillary excess. So as we all know, this patient's going to go into orthodontic appliances to prepare her for at least a one jaw surgery. At a minimum, she's going to get a maxillary impaction. Most of the time, that's not the case today. Most of the time, these patients are going to get a two jaw surgery. They're going to get a maxillary impaction and a mandibular advancement. But let me show you a dolphin representation of the maxillary impaction. So the oral maxillofacial surgeon is going to go in and do his or her magic. They're going to remove maxilla and move it up. And they're going to place rigid fixation. And in this diagram, it's only a one jaw surgery. So the mandible is going to auto rotate into a good occlusal relationship. As I said, most of the time, this is going to be a two jaw surgery, and it's going to be a BSSO on the lower and a maxillary impaction. I'm a big fan of orthodontic surgery still in my practice today. And I believe as a general dentist, a patient comes to me for two things, a new patient. The first thing they come is for a comprehensive exam. And the second thing they get is a comprehensive interdisciplinary treatment plan. And if on my problem list, there's a skeletal discrepancy, I believe it is my obligation as the restorative dentist to have that discussion with the patient. Clearly, I don't have the skill set to deal with it, but I can start the discussion. And if the patient shows an interest, then I'm going to make the referral. If the patient has no interest at all, I tell them, I understand it's a big decision, but just know that we can always have this discussion again in the future if you want to talk about it again. However, on occasion, I'm surprised and a patient will say, yes, I'm really interested in having a consult. So this was my patient. They got a comprehensive exam, had a discussion about surgery, and she chose to have it done. So there she is pre-op, and there she is post-op after her two jaw surgery. Could she have benefited from Botox? And the answer is yes. She could have benefited from Botox. It would have decreased her gingival display, but it would not have made her look like she looks on the right screen post-op. So once again, not only is this for aesthetics, but commonly there is a giant airway advantage to this also. And in fact, that's normally the way today I'm going to start the discussion. It's going to be an airway discussion rather than a discussion of aesthetics, at least to start with. However, it can be just the opposite. It can be vertical maxillary deficiency, and that's when the lower third of the face is short. Commonly, this patient has very little tooth display in full smile and certainly no tooth display in repose because the maxilla didn't grow vertically long enough to bring the teeth into the smile. There are two ways that we can deal with vertical maxillary deficiency. The first is with orthodontic surgery, and that is just the opposite of VME. It's a down fracture of the maxilla. So again, this is my patient. I've known this patient since she was just a little girl. One of the favorite families all time in my practice. She has a sister, and I love both of the girls, and their parents are just the greatest. And we started talking about her vertical maxillary deficiency when she was young. Let's do the measurements on her. The lower third of the face is significantly shorter than the middle third. And why is that? Because the maxilla should be 1/3 and the mandible 2/3. She's 20% and 80%. So once again, I don't need a Ceph to make this diagnosis. I can make this diagnosis across the room. And as you start to pay attention and look for vertical maxillary deficiency, you're going to see it all the time. The world is full of people with vertical maxillary deficiency. So there she was with a little girl, and in big smile as a little girl, she was only showing half of her maxillary anterior teeth. And there she is as an early teenager. And once again, an ortho with the biggest smile, she can only show 50% of her maxillary teeth. And therefore, she can never have a dynamic smile with vertical maxillary deficiency. So when the time was appropriate, she went to the oral maxillofacial surgeon, and he did a down fracture of her maxilla. And she's been thrilled with this result and absolutely would go through it again for the result when asked, would she do it again? The other way to do it is with restorative dentistry. So the patient doesn't have tooth display. So by doing additive dentistry, we can get the patient a little more incisal display, both and certainly in full smile and maybe even a little in repose. So there's vertical maxillary deficiency, who chose not to have orthodontic surgery. I know you guys are all judging me because those teeth are really white and prosthetic looking, and I stand accused as guilty. However, I will tell you that he was the happiest person in San Antonio the day he got his front teeth, because he had dreamed all of his life of having a bright, white, dynamic smile, and that day was the first day that he got it. Okay, so what we've gone over in a fairly brief way are the 4 global diagnoses that dictate all interdisciplinary treatment planning. So the next part of the discussion is, how do you and I make a global diagnosis on a patient? And the answer is, all we have to do is to ask and answer the 5 core questions. And this is how you operationalize the concept of global diagnosis. So there are the 5 questions, and there are the answers. The mid-face and lower face in the normal patient should be 1 to 1. The average lip length is 20 to 22 in the young female and 22 to 24 in the young male. The average lip mobility is 6 to 8. The gingival line should be straight and parallel to the horizon. The maxillary central incisor on average is 10 to 11 millimeters long. And in the normal patient, you should be able to feel the CEJ and the sulcus. So these are the norms of the 5 core questions. So here's how the system works. On the top is the patient who has an ideal smile. On the bottom is a patient with a problem. So what I teach my residents in San Antonio is that you don't start by gathering numbers. You start by looking at the patient's face. And much of the time, you should be able to make a diagnosis based on a repose, full smile, and profile shot without ever making any measurements at all. The purpose of the measurements is to confirm what you're seeing. So I would propose to you that there's 2 things on the lower screen that aren't right. The first is the gummy smile from front to back. The second, the teeth are too low in the smile. There's only 2 reasons that teeth can be too low in the smile. One is vertical maxillary excess, and the other is dentoalveolar extrusion. So let's ask and answer the 5 questions. The first question is face height. And in a normal patient, the face height should be 1 to 1. In this patient, mid face is 60, lower face is 75. There's the problem. She's got a long lower third of face. Everything else about this patient, when we measure it, is normal. So what's your diagnosis? Vertical maxillary excess. Remember, cardinal findings: long face, gummy smile from front to back. Once you name it, then you can treatment plan it. It's either orthodontic surgery or it's masking treatment of the gummy smile with Botox. However, it can be just the opposite. It can be vertical maxillary deficiency. That's the short lower third of the face because the maxilla didn't grow vertically long enough. The treatment options are orthodontic surgery or restorative dentistry. And then, of course, the third skeletal discrepancy is the AP discrepancy, the class 2 or class 3 malocclusion, and that's treated either with orthodontics or orthosurge. So that's the skeletal component of the global diagnosis system. Let's do it again. Ideal on the top, problem on the bottom. So what do we see? We've got normal looking teeth. The length looks the same on the lower as the upper. However, we've got gingival display in the front, tapering down to none in the back. I've got a pretty good idea. Gummy smile in the front, normal looking teeth. I have a pretty good idea what's going on. I now make the measurements to find out. Her face height is normal. That's not the problem. There's the problem. She's got a short upper lip. Should be 20 to 22, and it's only 17. Everything else about her is normal. So that's my diagnosis. She has a short upper lip. So when you have a diagnosis of a short or a hyperactive upper lip, the treatment is Botox. All right, let's do another one. Ideal on top, problem on the bottom. So I'm sure everybody's seeing this now because I just beat you up with this for about 30 minutes, and that is dentoalveolar extrusion. We can see the concave gingival line from canine to canine. So face height is normal. Lip length and mobility are normal. There's the problem. Patient has a curved gingival line. Tooth length is normal. I can feel the CEJ and the sulcus. So my diagnosis is dentoalveolar extrusion. Once I name it, then I can treatment plan it. Remember, the 3 primary treatment options for the patient with dentoalveolar extrusion are orthodontic intrusion, functional crown lengthening, and restoring an increased vertical dimension. Okay, one more. Ideal on top, problem on the bottom. So I look at the teeth on the bottom and they look short to me. So she's got a gummy smile and short teeth. So we've all got a pretty good idea what's going on here. Base height's normal. Lip length and mobility are normal. The gingival line is straight. So far, we haven't found a problem. There's the first problem. Her maxillary central is only 8 millimeters long. So let's go through our differential diagnosis. Does number 8 look like a microdont? And the answer is no, it looks normal. Second question, does there appear to be incisal edge wear on 8 and 9? And the answer is no, there doesn't appear to be wear. It appears that she has normal incisal embrasures. So that only leaves us with one etiology for short teeth, and that's a third one, which is altered passive eruption. How do you make a diagnosis of altered passive eruption? You feel for the CEJ and the sulcus. And in this patient, we cannot feel it. So what do we know about this patient? Short tooth, can't feel the CEJ. She has altered passive eruption. Once you name it, there's only one treatment option for altered passive eruption, and that's aesthetic crown lengthening. So that's the way the system works. We have 5 questions that lead us through the 4 global diagnoses. So I've given you a really quick, dirty Cliff Notes version of global diagnosis. So let's finish the evening up making global diagnosis work in our operatories. And that's where DSD comes in, digital smile design. Digital smile design was a concept that was made famous by Christian Coachman. And I first heard Christian Coachman, and I didn't know him at the time. And I liked what he said, and I thought it was cool, but I set up some barriers in my mind as reasons that I didn't really need to implement it into my practice. The first barrier was technology. Back in those days, it was all done on Apple computers, and you had to be able to use Keynote and know how to work Keynote and do your own smile design. I really didn't care to fool with that. The second was sort of an internal barrier that I had in my own mind, and that is I've been teaching smile design now for the last 25 years. I mean, I'm pretty good at it. Do I really need to have a digital addition to the knowledge I've already got? Well, it turns out the answer is yes. I'm much better now than I used to be. So that wasn't a legitimate barrier. The third is the generic barrier for all of us, and that is change is hard. I'm going to assume that some of you tonight might actually be inspired to say, okay, now's the time. I'm going to jump and I'm going to start moving more into digital smile design. But it's hard to go back to the office and all of the things going on, coming in and going out to make a big change in your practice. And so those are the 3 barriers I set up in my mind. And so I didn't do anything for about a year. And one of my buddies came to me about 5 years ago and he said, you really got to go hear Coachman speak and take his residency program because what he does fits in so beautifully with what you do. So about 5 years ago, I went and took his 4-day DSD residency and got to know him and found him to be an amazing teacher, a really nice guy, but an incredibly smart person. I've learned a lot from Christian Coachman over the last 5 years. So in order to do digital smile design, you only have to have 3 things. You got to have a lab, you got to do some photographs and scans, and you got to be able to send it by email. All right, so let's talk about the first, and that's the lab. In order to use the DSD lab in Spain, you have to have gone through all the DSD courses. And so if you've already done that, then you already know that you can use a DSD lab in Spain, sort of the mothership. But if you haven't gone through a DSD residency program, you can't do that. But there are some labs in the United States that are DSD approved. So there's 3 of them. Here's the thing. DSD, or digital smile design, has become generically available everywhere. So I'm going to propose to you that you do not have to use one of these 3 labs to do digital smile design. Some of you have scanners in your office and you can do your own digital smile design, and you can do your own diagnostic wax ups, and you can print your own models. That's a great way to do it. Many of us don't have all of that in our offices yet. So I'm going to bet that in California, Northern California, there are a bunch of labs within a few miles of where you practice that will provide digital smile design for you. This just happens to be a lab in my neighborhood that provides those services. It's about to do the smile design, the digital wax up, the printed cast, and the PVS matrix to do the motivational mock-up, which is what I'm going to talk about. It's a little under $500. So there is an expense associated with this. And if you can do it in-house, you can do it for about $25. And so there are some real advantages to being able to do this in your own office. Another way to do it is to send it to an outside company. This company happens to be in Brazil, but they do a comprehensive, good job of digital smile design. And you say, I don't want to deal with somebody in Brazil. I don't have to mail things back and forth. There is no mailing. This is all done with STL files and slideshows. So this can all be done back and forth by email. It doesn't really matter where the lab is. They will do a 3D planning for you, send you the STL files, and either you'll print the cast yourself or you'll get a lab in your town to print the cast. The next step is incorporating facial scanning. And I haven't incorporated facial scanning yet, and I'm going to show you why I haven't yet, but I think it's an interesting technology, and you can certainly incorporate it into your digital smile design, but it's not a requirement. And I've been doing DSD now for about 5 years, and as I said, I'm not using facial scanning at this point. This is a fairly new company, SmileFi, and I'm going to assume that many of you have seen the advertisements because it's all over the place. And this really is a wonderful company. The guy that started this company, his name is Ralph George. He's an incredibly brilliant guy. And he has created an app that you can download onto your laptop or even better onto your iPad. And you can do a quick design on a patient literally as they sit there. You can take photographs with your iPad. It uses AI to help you with the smile design. And in a matter of just 2, 3, 4 minutes, you can do a smile design right chairside for the patient. Once you decide what you're going to do, you can then convert that from 2D to 3D and print models and so on. So I think SmileFi is one really good place that you might look into this if you're about ready to jump into digital smile design. Regardless of where you do this, you're going to have to take some photos. So this is Elizabeth. This is the patient we're going to treat from beginning to end. In order to do a digital smile design, at a minimum, you have to have 5 photographs. Traditionally, it's 5. The first 2 photographs we see are full face repose and full face full smile. These are framed nicely, and that's exactly what you would want. You don't want the patient looking up, down, side to side. You want to have the patient looking straight at you so you see approximately the same amount of one ear as the other. And the reason that's important is because the lab technician is going to overlay different images on top of each other. So the first 2 are full face repose, full face full smile. The 3rd and 4th images are the same thing in profile. And the 5th image is what Coachman calls the 12 o'clock shot. And I never took this photograph before I learned from him, but I've come to believe this is an important photograph to take. So you lay the patient back in a supine position, you come behind them, you parallel your viewfinder to the interpupillary line, you have them go into a big smile, and you shoot over their nose. You want to see the relationship of the incisal edges to the wet, dry border and full smile. So at a minimum, you've got to do these 5 photographs. I would propose to you that if you'll take a couple of more, the lab technician will be very grateful. It will make it much more efficient. Because once we take this shot where we're showing the relationship of the maxillary occlusal plane in relation to horizon, it's much clearer that this patient has a significant cant down on the left side. I also really like the photo on the right because it gives everybody a better idea about the verticality of the maxillary anterior teeth. All right, so far we've taken about 7 photographs here. Here's the question. Is this really a good full smile photograph on the right? And up until a few years ago, I would have said, yes, I think it's a very good shot. I took it. And we see there's a lot of tension in the mentalis muscle. that would indicate to me she's trying to smile. There's a lot of tension in the upper lip, and we can see quite a bit of gingival display, especially on the left side. So yes, I would say I think this is a very good diagnostic photograph. Well, Coachman challenged that idea for me, and he said, generally speaking, a patient will not go into a natural full smile when you voluntarily ask them to do it. In order to get a natural full smile, we should be shooting a video. So I have now incorporated a video into my diagnostic series. So we've taken about 7 photographs. We're now going to take out our iPhone and we're going to start videoing the patient. So patients are very comfortable looking at an iPhone, and you just tell them, I'm going to turn my phone on. I'm just going to take some pictures of you while we're talking, and then you start talking to the patient. And what I'm saying to the patient right now is, first of all, Elizabeth, give me a big smile. So I'm asking her to give me a voluntary big smile, and that's what I get. Now I'm going to start talking with her, and my goal is to make her laugh. So I'm going to say, what did you do for lunch today? And she says, I went and had beef and broccoli. And I said, I know you had beef and broccoli because I can still see the broccoli between your teeth. And she smiled and said, yeah, I'm saving it for later. And right there, I got what I wanted. All right, so now I can turn the video off, I can download it, and I can move just to that specific spot in the video and do a screenshot. And now I have a dynamic smile picture versus a voluntary photograph. So that was as high as we got with the photograph on the upper screen, and on the lower screen, that's the video capture. And I think we would all agree that the video capture is a much more difficult treatment position to work towards than the photo on the upper right. So once again, video, I think, is a very important part today of a good comprehensive aesthetic exam. So the classic study that looked at lip dynamics was done in 1984 by Chan. And many people are familiar with this study. About 20% had a low lip line, 70% immediate lip line, 10% a high lip line. But that was done based on photography. When that same study was redone 2014, the gummy smile went from 10% to 38%. So what this tells me is that, first of all, we cannot capture accurate smiles with photographies. The second thing it tells me is that the world is full of people that show quite a bit of gingiva in full smile. And it has forced me to reevaluate my whole belief system about the gummy smile. And in the last several years, I'm developing more of a love affair with the gummy smile than in the past. I was the guy in the past that if there was 2 millimeters or more of gingiva, it's got to be fixed. I'm not that guy anymore. If the smile looks good in the context of that patient's face, I'm happy with it as long as the patient is happy with it. All right, you got to couple all the photography with scans. So there's a scan of the upper and the lower arch. And some of you say, I don't have a scanner in my office. I can't do DSD. Well, that's not the case. All you have to do is to make Algin impressions and stone cast. And you can either have one of your buddies next door scan the cast for you and send you the STL files, or you can just send these casts to the local lab and they'll do the scanning for you. So the fact that you don't have a scanner in your office is absolutely no reason to not be involved in digital smile design. When I did Elizabeth's case several years ago, we did not have a scanner in our office. All right, so I'm going to send all of this stuff off to a laboratory. It doesn't have to be a DSD lab. And in fact, for most of you, it's not going to be. It's going to be a local lab. And using the principles that I've been teaching tonight and Coachman's been teaching and lots of people teach, it's principles of smile design. So the lab technician is going to overlay the scan of the maxillary cast into the patient's face. And then the lab technician is going to do a digital wax up. And the goal of the digital wax up is to idealize that patient's presentation, what we see between the upper and lower lips. So the proposal in this patient, in order to idealize her smile, and by that I mean a 10 to 11 millimeter long tooth that's about 80% as wide with a good gingival zenith and so on, and sizal edges to the lower lip and full smile, all of those things that we talked about. This was the proposal from the technician that designed it. The idea is that we need to go up about 1 3/4 millimeters, and we need to go down incisally about 1/2 millimeter. All right. Now remember, this is digital wax. All of this is being done digitally, not analog. So the lab technician is just taking this wax and putting it over the fronts of the teeth. So this isn't a diagnostic wax up to make provisionals. This is a diagnostic wax up that we're going to use to do a motivational mock-up in the patient's mouth. So I'm going to get this back from the laboratory in a slideshow. And this is going to be one of the slides, and I am to okay it. And when I got this back, I thought it looked pretty good on the left. I felt like the teeth needed to go higher on the right, or there was still too much gingival, on the left. There was still too much gingival display on the left. So I wrote a note back and said, I like the right, I don't like the left. So that was the first project. And they went up over the gingiva with the wax about 1 millimeter. That's the second project. And you can see they went up higher in the back on the second project, doubled the amount that they covered the gingiva with wax. So at this point, I okayed the digital wax up. So that's what it looked like the first time. That's after I asked for changes. Almost all the time when I'm dealing with a technician, I'm not satisfied the first time with what they've done. I ask them to make some changes. That's generally the case. Now, what I want you to look at on this cast is that this is additive. We're going to use this to do a motivational mock-up in the patient's mouth. So we can't use this for anything other than the motivational mock-up because it's just being added onto the facial surfaces of the teeth. And it's up over the gingiva also because that's where the margin of the crown ultimately needs to be, or the veneer. Now that 2D representation is turned into a 3D representation and a cast is printed. Once we have the cast printed, we now clean it up, remove the sprues, and we're ready for the magic. And the magic of DSD, in my mind, is the motivational mock-up. Let me just tell you about the last patient I saw today. The last patient I saw today was a 17-year-old young man. He's got little teeth. They're 7 millimeters by 7 millimeters. He's got spacing and he's got altered passive eruption. And he needed, ideally, to have crown lengthening and then the spaces closed with composite. He had visited with another dentist, and this other dentist had actually gone through a wonderful diagnostic process with him. He had scanned him, printed some models, and made 2 models, one that had just the spaces filled in like it would be composite, and then 1 model to simulate crown lengthening. And all it did was confuse the family because they looked at ugly, dark models like we're looking at there, and they couldn't visualize what it would look like. And I said, look, all we need to do is to do a little mock-up in your mouth with just closing the diastemas with composite, and then I'll pop that off and I'll do another motivational mock-up going up over the gingiva. And then we'll all get a vision as to whether or not the crown lengthening will really help or not. That was my last patient today. So I do motivational mock-ups in my practice a lot. So what we're going to do is we've now got the model and the tissue is covered to some degree with the digital wax. We can see where the margin is. So we're going to make a PVS matrix and it's going to be trimmed very precisely right to the edge of the digital wax up. Here are the 7 caveats of the motivational mock-up. We're going to put bisacryl in the matrix and seed it over the teeth. So the first thing I tell the patient, disregard the taste and the feel because it doesn't taste great and it's rough. Tell them this is just to give you a vision of what it's going to look like. It's got nothing to do with the way the final dentistry is going to feel. Second, don't forget to block out undercuts in the mouth. If you've got open gingival embrasures or you got bridges, you don't want to lock this motivational mock-up into the mouth because it takes a fun day and turns it into an unpleasant day. Third, place lubricants over composites because bisacryl will stick to composites. Fourth, use a pretty light colored material. I pretty much never do anything lighter than B1 and sometimes more of a bright white. Number 5, fill the stent with the bisacryl within 20 seconds. If you take more than 20 seconds, it will start to set up in the incisal edges and you will get voids. Number 6, Don't forget to remove the flash from the palate. When you pull the matrix out, it looks so cool in their mouth because it looks like $1 million just when you pull it out. You forget that you've got this big spur in their palate. And if you don't remember to go in and remove it, they're going to be uncomfortable through the whole experience. So remember to go in and take the excess off the palate. And then finally, when you're removing the whole thing, be sure and floss every tooth afterwards because almost always you're going to find some bisacryl in the embrasures. These are the limitations. You can't do it on a patient that's got a giant skeletal discrepancy, and you can't do it on patients whose teeth are really sticking out already. If they have very procumbent teeth and you add bisacryl on top of them, it's going to make it worse. So those are two limitations to a motivational mock-up. So this is Elizabeth. This is one of the first we ever did. So I'm going to show you what the mistakes were. So all you have to do after you blocked out undercuts is dry the teeth. My partner is going to be filling bisacryl into the matrix, and it's way overfilled. You only need about 1/3 of the bisacryl that we're putting into the matrix. If that were in the right place, only on the facial, not in the middle, but only on the facial, that first round would have been enough. This is too much. You don't need all that. Don't put any more. Oh, holy cow. That is like way too much bisacryl. Just a waste of material. All right, so I'm going to seat this in her mouth. It's a very positive seat. You're going to watch her flinch, but it's not because the matrix is uncomfortable. It's the cheek retractors. And you're not going to be using cheek retractors. I'm just doing this to show you. So we have a very positive fit in the mouth. It takes about 20 seconds for the bisacryl to start to gel. Once it starts to gel, you're going to go in and remove it in large pieces. And you're going to peel it away right along the carved matrix. So when you take the matrix out of the mouth, it's going to look beautiful. You're going to have no finishing to do on the facial surfaces. So now it's starting to gel. So I just go in and remove big chunks of it with cotton pliers. After we remove those big chunks, we let it sit for 3 minutes and then we pull it out of the mouth. Okay? That's what it looks like. So there's before on the upper, motivational mock-up on the lower. You can see where it's going up over the gingiva. You can see a little pink showing through close up. You can't see that back at the speaking distance. You can also see there's a little bit of extra bisacryl between number 8 and 9. More about that in a minute. The other way you can do this is you don't even have to do it in the mouth with the bisacryl. You can have the lab print shells for you. So instead of making a matrix and doing it with bisacryl, you just tell them to print shells for you, and they'll send you these shells in 3 pieces, two posteriors and 1 anterior. And all you do is take the shells out of the box, you put some flowable in them, and you just put them on the teeth and light cure them. That's all there is to it. You don't have to etch, you don't have to do anything. Just flowable will hold these in place in order for you to get a good photograph. So this is a patient that wanted more volume. She wanted brighter teeth, but she wanted more volume. And so there she is before and after the motivational mock-up. That took a minute to do. It took a minute to put the flowable in, squeeze those 3 pieces on, and light cure them. So now she has a sense of what it would look like to have a much broader, brighter smile. All right, so this is a video of a patient that I did one day doing a motivational mock-up. So he's getting ready to sit down. The motivational mock-up is in his mouth. I've cleaned the palate up. On the computer is the pre-op. So when he's sitting down, all he's seeing is the pre-op, and then he's going to lean forward as he looks at, as I click it, and the motivational mock-up comes up, the photograph of it. So here we go. So he's just seeing it before.
And this is the way it looks.
And that's what they almost always do. Almost always they lean forward into the computer. They then look at me. They then go back and look at the computer again, almost every time.
It's totally different. It's a miracle.
It's a miracle.
So that's where we're headed. That's going to take us a while to get there. Okay. But now you've got a vision, and I got a vision what this can all look like when we're at the end. Because that'll help you. Remember, this will help you when we're getting all the work done. You'll remember this is where we're going at the end. This is where we're going. Yeah. I'm so excited.
This is where he almost cried. He didn't quite, but he almost did.
Oh my gosh, thank you so much. Thank you.
All right, so once I'm sitting there with the computer and the photographs, that's when I start to talk about the treatment plan. This is done at the second appointment. I gather the data at the first appointment. The second appointment, I present the treatment plan. So they've seen what can be done, and almost always they will then say to me, Dr. Robbins, can you really do that? And I say, yes, I really can, and let me show you how. And then I go over the treatment plan. And with these adult patients, most of the time, they're going to need some gingival surgery and they're going to need some ortho. And the gingival surgery is easy to sell. I have no problem selling that at all. The ortho is much more difficult for the patients to say yes. And they're always surprised when I tell them they need orthodontics. They say, like on my teenagers or on my grandkids? Yeah, exactly, just like that. And they say, I don't mind the gum surgery, but I don't really want to get the braces. I don't want the braces. Do I have to do the braces? And I say, no, you don't have to do the braces. And then I point to the photograph and I say, unless you want that. And if you want that, you got to do the braces. So it puts me in a very powerful position. Now it's important. Coachman makes a strong point of this, and I'm going to make the same point. We are not manipulating patients to accept treatment they don't need. The goal of DSD is to help a patient make a decision that is in his or her best interest. So the next point I want to make is that you never do this. You never give a patient a mirror and let them look into the mirror. And the reason is because if you give them the mirror, they'll pull it right up to their face and they will see that little piece of viscocryl between number 8 and 9. And they will say, I don't like the way that looks. And you just ruined the whole experience. This is supposed to be a positive, emotionally rewarding experience for the patient. So never hand them a mirror. This should always be done either with photographs or with a video. So here she is pre-op, and there she is with the motivational mock-up. So with this on the screen, I would then start talking to her about what we need to do to get there. Now what? We've got a smile design. The laboratory gave that to us, but we don't have a treatment plan. That's not the laboratory's job. That's the dentist's job. So how do we make a diagnosis on Elizabeth? And I would propose to you a very good way to diagnose Elizabeth is to go through and ask and answer the 5 questions. So that's what we're going to do on her. Remember, the normals are 1 to 1, 20 to 24, 6 to 8 mobility. The gingival line should be straight. The central should be 10 to 11, and we should be able to feel the CJs and the sulcus. So I'm going to give you a moment to look at this. And in fact, I think even the better way to do it is to give you the norms on the left and Elizabeth on the right. So with the answers to those 5 questions, everybody looking tonight should be able to make a diagnosis on Elizabeth. And once you make a diagnosis, once you call it something, then there's only a limited number of ways to fix it. That's the beauty of the system. Once you name it, then you can treatment plan it. So I'm going to assume by this point, everybody's figured out what works and doesn't work. So her face height is normal. So we're going to get rid of that. Her lip length at 22 is normal. So that leaves us with 4 issues. She's got a hyperactive upper lip. She's got a curved gingival line and a cant. She's got short teeth, and we cannot feel the CJ and the sulcus. So that makes our diagnosis very easy. She's got a hyperactive upper lip. She's got dentoalveolar extrusion with wear and a cant, and she's got altered passive eruption. All right, so now I can very easily make a treatment plan for Elizabeth. I'm going to start out with aesthetic crown lengthening. I'm going to do pre-orthodontic bonding. Remember I said earlier this evening, every patient that's going to get restorative dentistry done, the teeth that are going to be restored are made, if they're going into ortho, are going to be made anatomically correct either before or during ortho. In this case, we're going to be doing it before the braces go on. After the orthodontist levels the patient orthodontically, we're then going to do veneers on 4 through 13. If at the end she'd like some Botox for the left side, then we can certainly offer that to her. So here we go. This is the day I did the crown lengthening. Notice I'm not leveling her bone with horizon. I'm leveling her bone with each individual CEJ. We're going to level the teeth orthodontically. So when I'm through with the crown lengthening, she's still going to have a cant gingivally the way she did before. It's just going to be higher on the teeth. At 3 weeks, we're ready to go. So in the morning, I did the pre-orthodontic bonding on the teeth. You can see I'm not straightening the teeth up with the bonding. I want to have the same cant before that there was after. I'm just making them anatomically correct to direct the orthodontic treatment. In the afternoon, she goes to my orthodontist, Dr. Norris. He puts his tabs in on the upper left and the lower right, and the magic begins. And this is what he was able to do in 3.5 months. In the old days, we would spend months and months and months and years leveling arches with horizon. But today, that's not the case. We got some benefit from the surgery, the wrap effect that comes with doing the surgery, surgically facilitated orthodontics, and we also had skeletal anchorage. The problem is that we're not doing restorative dentistry on the posterior teeth, just the anterior. Therefore, the posterior occlusion has to be correct. So the hard part today in our practice is not leveling arches with horizon. That's not the hard part. The hard part is getting the posterior teeth into a good occlusal relationship. So that took another year. So the whole case took about 15 months from beginning to end to get upper arch and lower arches level and to get the posterior teeth into a good occlusal relationship. So this is after the ortho appliances have been removed. The diagnostic bonding is still there. And then obviously it's everything, the teeth are in exactly the right place for me to now go in and do my final porcelain restorations. And they're going to be enamel bonded. All I'm going to do is remove the composite from the edges. That composite or that distance then becomes the incisal reduction for my porcelain restorations. So there she is post-ortho with the bonding still in place. There she is after the veneers have been placed. There she is a couple of years later. The veneers have been in 2 years. Pre-op and post-op. And thanks to my team. I have an amazing orthodontist. I'm sure he's known to some of you because he's developing a fairly significant following. His name is Tito Norris, and he is the most innovative orthodontist I've ever had the pleasure of working with in my almost 50 years. And also I have a wonderful lab technician in Boston. His name is Hiro Tokutomi, okay? So, in conclusion, I've given you a whole lot of information in a very short time on a Thursday night after been working at the chair for 4 days. If you want to take a deeper dive into Global Diagnosis, this is the book that Jeff and I wrote 5 or 6 years ago, and it has pretty much everything that I talked about tonight, except DSD. It doesn't have DSD in it. So this is published by Quintessence, and that's something that you could certainly access. The other opportunity is about 1.5 years ago, I started a virtual study club. It's called Global Diagnosis Education. We meet not every Wednesday night, 3 Wednesday nights out of every month at 8 p.m. Eastern, which would be 5 p.m. West Coast time. And we meet for 1.5 hours to 1 hour and 45 minutes. And it is an interdisciplinary study club that we talk about all the things that we talked about. And we do a lot of treatment planning between me and my partner, Jim Otten, and the members of the study club. So if that has an appeal, you can contact us at globaldiagnosisinfo@gmail.com. So I want to thank Dr. Pendekar again for the invitation to come tonight. It really has been a pleasure being with you. My very favorite thing to do is fly fishing. I love to fly fish, and I love to fly fish out west for trout. I didn't get invited to go fly fishing tonight, but I did get invited to do my second favorite thing, which is talking to a group of colleagues that have an interest in interdisciplinary dentistry as I do. So again, thanks to everybody for coming tonight. And with that, I will turn it back over to Megan.
Thank you so much, Dr. Robbins.
And I
We'll reach out to you.
Someone did ask a question. Can we do Invisalign instead of braces?
absolutely. And in fact, my orthodontist, Dr. Norris, uses quite a bit of Invisalign, but I would say when we're doing these more complicated cases like the one I showed you, he prefers to use traditional ortho appliances. But with a few exceptions, today we can do almost anything with aligners that we can do with traditional appliances. One of the very best interdisciplinary orthodontists in the world is Rick Robley, who practices in Fayetteville, Arkansas. And that's all he does, is very sophisticated, surgically facilitated orthodontic treatment. And he uses exclusively aligners to do it. And absolutely, this can be done with aligners.
And then one other person, oh yeah, he put this in the chat too. He wanted to know if there was a final result for the very first patient you showed. The one that said, I don't want to wait until I'm 75 years old.
Oh, no, I didn't have anything to offer her. We didn't have Botox 25 years ago.
Ah.
So in those days, we had nothing to offer her. Today, we could obviously offer her Botox, but no, we didn't have anything 25 years ago to offer that young lady.
Yeah, I think that's
That's
it.
it. I don't see
Yeah.
any more
I don't
questions.
see
Yeah.
more.
Thank you.
Oh. Somebody wanted to know what program you use to make your slides.
Well, the actual like animations and that sort of thing is made by Medical Illustrator. Remember, I told you I am a very low tech guy. That's kind of the
Okay.
whole point.
I think she's
probably-
thinking you're using something magic here.
No, if I'm not the oldest guy on this program tonight, I'm almost the oldest guy. And the point is if I can do DSD, everybody can do it. So no, I cannot make beautiful slides. I have a Medical Illustrator that does that for me.
Who probably uses some fancy program.
Yeah, for sure. Doesn't matter to
Yeah.
me. Just as long as I get the slides, I don't care.
Thank you,
Well,
Dr. Robbins.
thank you very much.
Thank you and happy
appreciate it.
weekend
Thank
to you
you.
all. We're
Thanks.
almost there.
Thanks everyone for joining tonight. Keep smiling, stay safe, and we'll see you guys soon. And thank you again
Thank
for a
Bye-bye.
you.
wonderful lecture
Thank you.
tonight.
Thank you, everybody.
Bye-bye.
Good
Bye,
night.
everyone.